My name is George Theroff. I'm a second-year Med Peds Fellow at St. Louis University, and I have the privilege of introducing Dr. Beth L. Jonas. Dr. Jonas is the Rees Foundation Distinguished Professor of Medicine and Chief of the Division of Rheumatology, Allergy, and Immunology at the University of North Carolina at Chapel Hill. Dr. Jonas was the Rheumatology Program Director at UNC from 2001 to 2018 and was awarded the ACR Distinguished Rheumatology Program Director in 2015. She has previously served as chair of the ACR Committee on Training and Workforce and has served as co-chair of the ACR in Training Examination Task Force. Dr. Jonas currently serves on the ACR Workforce Solutions Committee. She will be presenting on a very high-yield topic, musculoskeletal radiology. Thank you, Dr. Jonas.
Thanks so much, George. It's a pleasure to be with you all this morning, and I want to welcome all of the new rheumatology fellows. I hope you're having a great start to your academic year. I'm going to share my screen. I'm joining you today from the clinic at the University of North Carolina in Chapel Hill, where we have fellows clinic. So if someone opens the door and asks for help, you'll know what happened. I'm going to try to focus here this morning. Hopefully you guys can see my screen. Are we good, George?
Yes, we're good over here.
Perfect. All right. So what we're going to talk about for the next chunk of time is really plain radiography for rheumatology fellows. I have no disclosures, and here are our learning objectives. First of all, I want you to develop a systematic approach to the interpretation of plain radiographs in the evaluation of arthritis. I want you to be able to describe the plain radiographic features of the most common forms of arthritis. And at the end, we're going to apply our knowledge to make a diagnosis of arthritis. And hopefully that will be kind of a fun little activity. So there are a lot of imaging modalities that you're going to learn about in your fellowship, no doubt about that. We're going to focus primarily today on plain radiographs. But let's talk about some of the other ones before we jump into that. All of you probably in your programs are going to learn about musculoskeletal ultrasound. This is available at the point of care in most academic and other centers, really at the bedside in the rheumatology clinic. It is really good for imaging soft tissues, less so for bones, but you can see erosions and other bony features, but it's very operator dependent, and you're going to learn that when you get going with ultrasound in your clinic. MRI is also very good for imaging soft tissues. It can assess inflammation and look at synovitis particularly. It is very sensitive for early bony changes, but not specific. And so it's really hard to use MRI and interpret that for erosions. And of course, it's very expensive. CT scanning is very good for imaging bones, and it's more sensitive than plain films, but has a high radiation exposure and is relatively expensive. One of the more newer modalities, dual energy CT. I don't have any CTs on this talk this morning, but this is a new technology, very useful for crystal-induced arthritis, and hopefully you'll have a chance to look at that in your institutions. But plain radiographs are really the workhorse of what we use in our clinic day to day. It's very good for imaging bones, but relatively insensitive in early arthritis. So most patients who are going to come to you with very early disease are going to have normal radiographs. But the radiographs are really useful as a sort of a baseline test. It's available in most offices and can be very useful in monitoring disease progression in arthritis. So one of the questions that I get all the time is, patient comes to you with musculoskeletal pain, which x-rays do we order? You do not necessarily need to image every involved joint. This is ridiculously expensive and has a lot of radiation exposure. So you want to tailor your ordering to the suspected clinical diagnosis. So if you're suspecting rheumatoid arthritis, the patient has peripheral joint disease, small joints of the hands and feet, you're going to want to, x-ray the hands and feet. If you're worried about an axial joint disease, such as ankylosing spondylitis, you want to image the sacroiliac joints and the spine. If you have a patient who has just an elbow involved, obviously you're going to you're going to image the involved joint. But you want to sort of, based on your history and physical, come up with a working diagnosis, establish the pattern of joint involvement, and then order your x-rays accordingly. So I put this up to remind you, there's a lot of anatomy out there you're going to want to review. It's really important to know the anatomy of the bones of the hands and wrists, both to understand what's happening in your patients and also to describe the features on radiographs when you're talking to people about what the findings are. And there are certain patterns of bony and joint involvement that are going to be sort of characteristic of the different forms of diseases, different forms of arthritis. And so knowing this anatomy is very, very important. And everyone has their little mnemonic for remembering the wrist joint, the wrist bones and whatnot. So let's talk about radiographs of the hands. And this is going to be the bulk of what we discussed this morning. Radiographs of the hands are most informative for screening patients with suspected arthritis and also may be helpful in monitoring progression. We generally recommend, when we're looking at hand radiographs for arthritis, two views. The PA view, which you see here on the top, and then the Norgard view, which basically has your hands like this, and you can sort of see the pisiform bones. That's probably the only X-ray that where you can see the pisiform, which can be very important because that may be a site of early erosion in rheumatoid. Sometimes we call this the "you're in good hands with Allstate" view. So you just position the hands like this. What's really important is that you develop a very systematic approach when you're looking at hand radiographs. So you want to look at radiographic changes in specific joints and then the distribution of these changes within the hands and wrists. And we're going to go through sort of how to do this. So there's not one right or wrong way of doing this. It's just really important that you have a system and you do it the same way every time. So I usually start by looking at the soft tissues. I look for swelling, I look for calcification, I look for foreign objects. The mistake I think a lot of people make when they're new at this is you throw those films up and everyone's trying to look at erosions, looking at the bones. And then what happens is you miss all the other features of the X-ray. So I really encourage you to focus on the non-erosion part of the X-ray first. So soft tissues, then I look for the alignment of the bones. Is that alignment normal? Is it abnormal? Then I look at bone mineral density and look to see, is there osteopenia? And if so, is it diffuse within the whole bone or is it periarticular just in the regions around the joints? After I've done all of that, then I start looking at the joint spaces themselves to see if there's joint space narrowing and whether that narrowing is uniform or non-uniform. And I'm going to show you lots of examples as we go forward. And then finally, look for erosions. What joints are they at? Where in the joint is the bone eroded? And are there other associated findings that might help you in making the diagnosis for the kind of arthritis that has caused that erosion? So the other thing is you don't want to forget to look for fractures and other non-arthritic findings. And we're going to go through a few of those this morning. And again, you want to just take a very systematic approach. So we're going to look at these multiple radiographic changes which you can describe that occur around the joints: soft tissue swelling, subluxation, malalignment, dislocation. We talked about the mineralization of the bone, osteopenia. If there's calcification around the joint can be useful, joint space narrowing, erosion, and any bony production. So those are kind of the features that we are going to be looking to be able to describe as we systematically go through the X-rays. So obviously you don't need an X-ray to know if there's soft tissue swelling. Hopefully you've seen that patient in your clinic and you've been able to really look at their joints in front of you. And so although as you know, swelling can come and go. So the patient may have had the X-ray 3 weeks ago when they had a lot of swelling, and then they come to you and they don't have swelling. So that happens. But if you have a contemporaneous physical exam and X-ray, you should be able to see that soft tissue swelling on your physical exam. But you're also going to be able to see it on the radiographs. So soft tissue swelling around a joint or a joint group may be symmetrical, or it may be asymmetrical. So it may occur on both sides or on just one side. There may be fusiform soft tissue swelling of a whole digit. Sometimes we call that dactylitis or sausage digit. Or there may be nodular soft tissue swelling, sort of lumpy, bumpy, scattered soft tissue swelling. And you want to just describe what you see. So here's an example. On the left, we have a normal hand radiograph, and I encourage you to just look at a lot of normal films, because unless you know what normal is, you're not going to know what abnormal is. So on the left, we have a normal plane radiograph, normal, no soft tissues look normal, the alignment is normal, the bone density is normal, the joint widths are normal, and there's no erosion. I know I went through that fast, but we're going to do a lot of that. And on the right, you see just this sort of diffuse soft tissue swelling. You can see really around each of the digits how that soft tissue looks sort of very swollen. Okay, and that can be helpful when you're looking at films. This is a patient, left is normal, and on the right, there's soft tissue swelling really just around the index finger. And, oops, sorry. You just kind of get the feeling like there's dactylitis. Also on this one, there's a little bit of an erosion. So this is a patient who has psoriasis and psoriatic arthritis, and you can see this diffuse swelling of the whole digit, dactylitis. There's also an erosion. We'll get to that later, but this sort of very thick and swollen digit, this can occur in the finger and it can occur in the toe. This is an example of lumpy, bumpy swelling. So again, normal radiograph on the left, and on the right, you see this, a lump here, a lump here. There's some soft tissue swelling here. There's soft tissue swelling here. If you're really looking, there's probably some soft tissue swelling here, down next to the radius. So multiple areas of soft tissue swelling. There's also in this bump a lot of calcification, and this is actually a patient with gout, and this is essentially a tophus. So next, we're going to look at alignment and subluxations. Again, on the left, we see a normal radiograph of the hand. And on the right, you can see that the digits are deviated in the ulnar direction at the level of the MCP joints. So this is a characteristic finding in long-standing rheumatoid arthritis. Early on in the course of the disease, this may be reducible. So when you're seeing a patient, you may be able to straighten out those digits. But over the course of the disease, that may become increasingly fixed. Ulnar deviation is also seen in patients with lupus who have Jacquard's arthropathy. That also may be reducible early on. So when you look at this film, you want to describe the deviation of the digits to the ulnar direction. This is a patient with very long-standing rheumatoid arthritis. There are lots of features on this film, which we'll not going to look at everything, but you can see both on both hands, there's ulnar deviation at the MCP joints. The other thing you see here, which is not always commented on, is actually radial deviation at the wrist. So radial deviation at the wrist and ulnar deviation at the MCP joints is characteristic of a patient with long-standing erosive and deforming rheumatoid arthritis. So I'm gonna walk away for a second from the hand films and just mention the cervical spine. The cervical spine is a place where there can be malalignment and subluxation in patients with rheumatoid arthritis, as well as patients with ankylosing spondylitis and other spondyloarthropathies. And you need to sort of know about how to assess the cervical spine to look for subluxation. And the area that's usually at risk in patients with rheumatoid arthritis is the upper cervical spine, the C1, C2 articulation, which can be unstable in patients with rheumatoid arthritis. And so this is a picture that sort of helps you visualize this. So you have your atlas, which is C1 on the top, which forms a ring. And then the axis, which is C2, has a little bony excrescence called the dens, which fits up into the atlas. And when there is active rheumatoid arthritis and the patient is extending and flexing their neck, there may be an increase in the interval between the atlantis and the dens axis. I'm sorry, the atlanto and dens interval, and you can see that here. And a normal excursion is less than 3 millimeters, and in patients with rheumatoid arthritis who have cervical instability, that might be greater. The reason why that's important is that there can be pressure on the spinal column and cause neuropathic features if this is not identified early. So you need to be familiar with that, and hopefully you'll have time to practice that in the clinic and as you're looking at radiographs. So next, let's talk about bone mineralization. The overall mineralization is estimated by measuring the cortices of the metacarpal shaft of the second or the third digit, and here we can see it in the third digit, and you can see that this is the metacarpal shaft. Has cortex on one side and cortex on the other side. The sum of this should be equal at least to 1/2 of the distance across the shaft. So this is normal mineralization of the bone. In this case, on the left, there's diffuse demineralization of the bone, and you can see on the third metacarpal shaft that the distance of the cortices is less than 1/2 of the distance across the whole shaft. So there's diffuse osteopenia demonstrated on this radiograph. On the right side, the cortex of the bone may be also down, but you primarily see focal osteopenia at the periarticular bone. So here at the MCP and the PIP, you can just see how washed out the bone is in the periarticular regions. And that is really just a marker of inflammation. And you can see this even in very early arthritis before there's erosion. So patients with rheumatoid arthritis or kids with JIA or other forms of inflammatory arthritis may have this focal osteopenia. And that may be a clue to you, if you don't have any other clues, that there's inflammation at those joints, and you're going to need to be on the lookout for erosive disease and further progression. So next we look at calcification. There may be calcified masses in the soft tissue, as I showed you just a few slides ago when we looked at that lumpy, bumpy soft tissue swelling with the calcification that I told you was a tophus. That's typically what happens. A lot of tophi are, you can't really see them because they're not calcified, but when they become calcified, you can. You may see chondrocalcinosis, which is calcium deposits in the cartilaginous tissues in or around the joints. There may be calcification of tendons, such as calcific tendinitis. I'll show you a couple examples of that. And there may also be calcified vascular structures. So in our patients with metabolic disease, diabetes, hypertension, chronic renal disease, they may have calciphylaxis, they may have calcification in the vascular structures. So as I mentioned a second ago, the urate crystals of gout are not radiopaque in and of themselves. However, when the urate crystals deposit in soft tissues and form a tophus, they can have calcium precipitate within that tophus. And so in those cases, the tophi may be radioopaque. So that can be helpful when you're trying to make a diagnosis of gout. CPPD, or calcium pyrophosphate dihydrate crystals, deposit in hyaline and fibrous cartilage, producing a radiographic picture of calcified cartilage, or so-called chondrocalcinosis. And you can see this in CPPD arthropathy, but we sometimes will just see chondrocalcinosis in and of itself without any form of arthropathy, and that will be something that you are able to delineate from the patient's clinical presentation. So it's not uncommon periodically to get a consult. Patient had a knee x-ray for whatever reason, and there's chondrocalcinosis. Do they have arthritis? And sometimes they do, and sometimes they don't. Hydroxyapatite deposition, and hydroxyapatite is another crystal-induced arthritis. This may appear as a calcified mass, not usually in the joint per se, but around an affected joint. Those patients generally present with an acute monoarticular pain with some swelling. And then you get your x-ray, which I'll show you a couple of examples of in a minute, that show you this, this deposit around the affected joint. So on the left, we can see again this lumpy, bumpy, soft tissue swelling, and then this tophus, which has been calcified, that you can see here. I'll also point out that there's some swelling here in the fifth PIP, and there is an erosion of bone there. That's pretty characteristic of gout, but we're getting ahead of ourselves a little bit. On the right, you can see this area of chondrocalcinosis. So this is the area of the triangular fibrocartilage complex, or the TFCC. And there are three synovial compartments that really insert on the ulna. And this is a very classical place to see chondrocalcinosis in patients with CPPD arthropathy. And these patients can present a lot like rheumatoid arthritis. They tend to be older, sort of 60s, 70s, maybe a little bit older than that. They can have polyarticular inflammatory arthritis that can look like rheumatoid. But if you see this chondrocalcinosis in this area, that is very characteristic of CPPD arthropathy, and can sometimes help you make that diagnosis. Like if you have a patient who's got polyarticular inflammatory arthritis in the hand, rheumatoid factor is negative, CCP is negative, there's really nothing else going on that makes you think about rheumatoid, and you see that, then it's more likely to be CPPD arthropathy. So those particular radiographic features can help you make a diagnosis. These are two examples of acute calcific periarthritis from hydroxyapatite deposition. Up here, you can see this sort of lump of calcified stuff. This is actually probably in the supraspinatus tendon, which is kind of running here through the rotator cuff over the top of the humerus. And those patients present with acute pain, swelling, and it's really uncomfortable. And you see this on x-ray, you've got a diagnosis. It also can happen, really can happen in any joint, but here's an example of it happening in the first MTP. And remember, someone presents with an acute monoarthritis of the first MTP, most people are going to go right to gout in their head, which is, you know, not completely wrong, but you want to make sure that you've thought about all the other things that can cause a monoarthritis in the first MTP. So gout can do it, osteoarthritis can do it, and hydroxyapatite deposition. So you get your x-ray and you see this, and you've probably made your diagnosis just on the basis of the radiographic features. So this is an example of a patient that has calcified arterial structures, and you can see that really all through the hand. And sometimes it's so obvious you can sort of make out all of the structures, but you can see here, and here, and here, you can see all of the arterial structures in the hand. So this is calcification of the arterial system, again, usually associated with metabolic syndromes, hypertension, CKD, and the like. So other things that we're going to see in rheumatology that cause calcinosis include systemic sclerosis, and this is really impressive example. This is a patient with systemic sclerosis who has tremendous calcification in multiple digits in the soft tissue and the Achilles tendon, even on the plantar surfaces of the foot. So systemic sclerosis can cause calcinosis. You can see this also in dermatomyositis. This is something called synovial chondromatosis. This may be the cause of a monoarthritis or a monoarticular pain syndrome. And you can see here, these are essentially rests of synovium that have become calcified. And they really inside and around the joint. You can see it. This is obviously the elbow. You can see this at the knee. It happens at the hip. It's usually a large joint. And the treatment for this is actually surgical. We send these folks to our surgical colleagues and they go ahead and clean these things out. They can cause pain. They can also cause dysfunction, loss of range of motion. So next we're going to move to joint space narrowing. All arthropathies pretty much by definition cause loss of joint width to varying degrees and at different rates. And remember that when we talk about the joint space, when we're looking at a plane radiograph, what that basically means is the amount of cartilage that is in between the opposing bones in a particular joint. So the loss of joint width is essentially a surrogate marker for cartilage loss because we can't really see cartilage on a plain film. And this joint space narrowing may be uniform, same across the whole joint, or it may be non-uniform. And identifying whether it's uniform or non-uniform will help us support a diagnosis. So here are a couple of examples on the left. This is a finger, obviously, that has a arthropathy that's involving the DIP and PIP joint. And in this PIP joint, you can see that one side of the joint is narrower than the other. So this is non-uniform joint space narrowing. On the right, now we can look at really all of the MCPs, which are all narrowed. And if you look at an individual one, so this is the third MCP, you can see across the whole joint, it is uniformly narrowed. So this is uniform joint space narrowing. And in general, arthropathies that cause uniform joint space narrowing are going to be inflammatory, and arthropathies that cause non-uniform joint space narrowing are degenerative or non-inflammatory. This is a general rule of thumb. There are going to be exceptions to that rule, but when you see uniform joint space narrowing, you should be thinking about inflammatory diseases such as rheumatoid arthritis, psoriatic disease, reactive arthritis, and the like. So this is a patient who has pretty much uniform joint space narrowing throughout all of the MCPs, and there's probably some ulnar drift in a number of these joints, and this is a patient with rheumatoid arthritis. And these are knee films. We haven't really looked at knees, but I think this kind of drives home the point about uniform and non-uniform joint space narrowing. So in this case, the medial joint width is much narrower than the lateral joint width. So this is very characteristic of osteoarthritis, and you can see some osteophytes here at the medial joint line. As opposed to this knee where it's not exactly uniform, but it's much more uniform than the previous one. You see the lateral joint width much wider than the medial, and here pretty much closer. So much more uniform joint involvement in patients with inflammatory disease. So these films actually come from the ACR collection, and for those of you who are not familiar with this, the ACR has a really lovely collection of all kinds of images, the Rheumatology Image Bank. And so when you're giving talks or looking for examples, you can always look through those image banks and look for pictures. And this slide comes from that image bank. This is a patient with osteoarthritis. This is the knee x-ray at the time of diagnosis, and you can see the medial and lateral compartment are pretty well preserved. 4 years later, there's some loss of the cartilage in the medial aspect and the development of some osteophytes. And then 7 years into the course of the disease, the medial compartment is essentially bone on bone, but the lateral compartment still looks like there's a fair bit of cartilage. Now, this x-ray shows you progression over 7 years. The rate at which patients will develop this essentially end-stage osteoarthritis is highly variable, but this is a pretty characteristic example. So finally, let's talk about the patterns of bone erosion. Bone erosion is really the hallmark of inflammatory arthritis. The location of the erosion and the characteristics can help you make a diagnosis of what form of arthritis this is. So juxta-articular erosions, or what we call marginal erosions, and I'll show you what that is in a minute, is characteristic of rheumatoid arthritis. Erosions that are central in the joint are characteristic of osteoarthritis. When erosions occur a little bit more distal to the joint, beyond the margin, that's usually seen in gout. And patients with gout will sometimes have like this bony overhanging edge. If you see a pencil and cup deformity, so sort of one bone is sort of stuck into the next one, that we see in aggressive psoriatic disease. And the presence of new bone formation or periostitis is associated with the seronegative spondyloarthropathies, such as psoriatic disease, reactive arthritis, ankylosing spondylitis, and IBD-associated disease. Now, these rules are not hard and fast, but they're kind of a helpful guide, and you're going to let your clinical skills guide you. So you're going to take a history, you're going to do a physical exam, and you're going to have imaging, and you're going to try to sort of put that whole story together. Sometimes your history and physical sends you in one direction, and your radiograph sends you in another direction, and your job is really to put all of that together. So the x-ray is really only one piece of data that you're going to use to make a diagnosis. And just about 15 minutes ago, we saw a patient who had osteoarthritis, who was also on anastrozole, was developing some hand symptoms related to that. And the radiologist read an erosion, a bony erosion, that made me think about rheumatoid arthritis, which had not been on my initial differential diagnosis. I'm not going to ignore that finding, but it does make us think we have to really tie together all of the pieces of our workup and not just make a diagnosis on a radiograph. And that's the fun part of rheumatology. So you'll get good at it in time. So this is an example of central erosion, and I point, this is a seagull and a sea, so we can feel like we're at the beach here. Sometimes this is called a gull wing deformity. You can see here this central erosion. So there's an erosion in the center of this DIP joint, and it kind of looks like the gull wing of a seagull flying out over the ocean. You can see it here. It's most characteristically seen at the DIP in patients with osteoarthritis, but you can also see at the PIP joints. You can see that here at this second PIP in this patient. This is an example of juxta-articular or marginal erosions as seen in rheumatoid arthritis. And you can see where my little yellow arrows are right at the edge of the bone, just really where the synovium inserts on the bone. So, you've got your joint capsule, and then your synovium kind of makes a little loop around, and that's really where the erosions occur in rheumatoid arthritis. So these are kind of subtle here, much more obvious here in the feet. You can see marginal erosions here, here, here. Actually, you can see it here also. And that is seen in rheumatoid arthritis. So this is a patient with gout. So this is a first MTP. there's this tophus here that's calcified. And then you see like something has just taken a bite. And actually, if you were to stick a needle in this erosion, there's probably monosodium urate in there. And sometimes we'll do that with ultrasound. But what's characteristic here is this overhanging edge. So something's taken a bite, and then there's this edge. And when you see this, you should be thinking about gout. And same here in this first MTP, you see this overhanging edge. Now, I will say you might look at the joint here and say, oh, that looks like a marginal erosion, and you wouldn't be wrong. But then there's this lumpy, bumpy soft tissue swelling, which is likely your tophus, and this overhanging edge. So it's much more likely if you're looking at this film, and this is the only piece of information you have. And of course, you will have more information than this. This is more likely to be gout because of this lumpy, bumpy soft tissue swelling and this overhanging edge. It would be unlikely to see an overhanging edge in a patient with rheumatoid arthritis. So, hopefully we don't see this that much anymore, but you will see patients who have very, very aggressive disease. And here we can see a pencil in cup deformity. There's a couple of places where you can see it. There's a pencil in cup here. You see the way it's just kind of impacting into the more distal bone. There's a pencil in cup here, pencil in cup here. It's sort of developing here. And when you see that impaction of the more proximal bone sort of eroding into the more distal bone, this is a pencil in cup deformity. It's very characteristic of psoriatic disease. So around the joints, you may see bone production. So periosteal new bone formation is new bone that's deposited along the shaft of the phalanx or in the metaphysis just behind an erosion. And we see this very typically in patients with psoriatic disease. So if you see a pencil and cup deformity, evidence of uniform joint space narrowing, and periosteal new bone formation, that can help you make a diagnosis. You can also see bone that's formed at tendinous insertions. This is often associated with the spondyloarthropathies or an enthesopathy, or basically inflammation where tendons or ligaments insert onto bones. And then you can see bony ankylosis, which is when there are essentially bony bridges between two joints, and then that joint becomes immobile. The arthritis can be very aggressive, destroy the cartilage, and then it just becomes fused. Overhanging edges are bony productions, and we just looked at that in gout. There may be subchondral bone thickening, which is reparative bone, which is laid down just beneath the cortical line. And we usually see this in osteoarthritis. We had a couple of films about that a minute or two ago. And then osteophytes are these little bony extensions that come off the normal articular surface and are usually related to osteoarthritis. So here are some examples of periosteal new bone formation. You can see that here, 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 and here. And this is a patient with a spondyloarthropathy. You can see periosteal new bone formation here. This is a patient who has bony ankylosis. So there's complete loss of cartilage, and now that joint is essentially fixed because the bones have bridged. So this is the scaphoid bone and the trapezium, and there is an area of subchondral sclerosis, which we see in patients with osteoarthritis. And you can see that in a lot of different joints, but we often see it in osteoarthritis. You can see that there's some joint space narrowing at the basal thumb joint also in this patient, which is, in terms of the location of the arthropathy, very much associated with osteoarthritis. So here's a couple of examples of osteophytes. You see these kind of little bony things that are sticking off the bones here and here. This is that gull wing deformity picture, but that's the osteophyte. Sometimes we'll see these on the MCPs, so-called hook-like osteophytes, because they look like hooks. We can see this in calcium pyrophosphate deposition arthropathy. Hemochromatosis should be on a differential when you see that, and you can sometimes see it in garden variety osteoarthritis. So we're not going to spend a lot of time talking about the sacroiliac joints, but this is a radiograph that you're going to get good at looking at. So this is a patient with active sacroiliitis, and you can see that there's sclerosis of the joint on the iliac side and some erosion of bone, probably also on the right side too. In this picture at the top, you can see essentially fusion of the sacroiliac joints. You don't see any joint at all. They have just completely fused. And you can live a happy, healthy life without sacroiliac joints. The problem is that oftentimes in patients with spondyloarthropathies, that can also then involve, the rest of the axial skeleton. Now, this is something that we see periodically that often gets misinterpreted as sacroiliitis. And this is something called osteitis condensans ilii. And this almost triangular shaped increased bone mineral density, more likely to be seen on the iliac side, and it's symmetrical, bilateral in women who are multiparous. So you can develop this sacroiliitis mimic. So if you're seeing a young woman with low back pain, who's multiparous and has this finding, this is not a spondyloarthropathy, this is osteitis condensans ilii. So pattern recognition is really, really important. If you've got DIP and PIP involvement, you're going to be thinking about osteoarthritis, erosive osteoarthritis, and sometimes psoriatic arthritis. If you are seeing new bone formation, that might help you make a diagnosis of psoriatic disease. Patients with rheumatoid arthritis tend to have involvement of the MCPs and PIPs, often with the wrists, and sparing the DIPs. So if you see that pattern, you may want to be thinking about rheumatoid arthritis. The spondyloarthropathies, such as psoriatic disease, reactive arthritis, and ankylosing spondylitis, can have erosions and new bone formation, but often also involves the DIPs. So DIPs are very rarely involved in rheumatoid arthritis. So if you've got DIP involvement, you want to be thinking, could this be another inflammatory arthritis such as psoriatic disease, or is it erosive osteoarthritis? MCP involvement, usually the inflammatory arthropathies, and CPPD. So if you see hook-like osteophytes and MCP involvement, the classic presentation for CPPD arthropathy is second and third MCPs with the hook-like osteophytes. And gout can do whatever it wants to do. It's all over the place. It does not have a classical pattern. It's not usually symmetric. It's kind of random. But again, if you've got lumpy, bumpy, soft tissues, and in one of these unusual patterns, you want to be thinking about gout. But gout can also present with a symmetric polyarthritis. So yeah, there's that. So again, your patterns of joint involvement, you want to learn this: primary osteoarthritis, DIP, basal thumb joint, rheumatoid arthritis, wrists, MCPs, PIPs. Psoriatic disease can do a lot of different things. It can cause inflammatory arthritis of the DIPs. It can give you something we call array distribution. So all of the joints of a single digit, those are the patients who present with this dactylitis. I just mentioned CPPD arthropathy, second and third MCPs classically, and the wrist, and then gout, which can be quite random. And in the feet, gout, as we mentioned, has a propensity to involve the first MTP, but can really involve any joint in the foot. Rheumatoid arthritis, usually the forefoot, the metatarsals, and more distally, but also the midfoot. Psoriatic disease can give you a dactylitis, as we mentioned, and then also cause a more symmetric disease. Reactive arthritis can pretty much do anything. And I want to just mention there's a diabetic neuroarthropathy, or so-called Charcot joint, can give you arthritis really in the midfoot. And this can be very aggressive, and it can be very inflammatory, and it often is confused with other forms of arthritis. So if you have someone who's a diabetic, who may have some neuropathy, and poorly controlled disease, and they have midfoot arthritis, you want to be thinking about a diabetic neuroarthropathy. So there are lots of radiographic measures that you're going to come across. I just want to mention one because you're going to read about it in the literature as you're reviewing your clinical trials, and that is the van der Heide modification of the Sharp score. And this is the scoring that's mostly used in RA clinical trials. There are other scores in the older literature, the Larson score and the Gannett score. But when you're reading most of the literature in rheumatoid arthritis, you're going to be looking at the van der Heide modification of the Sharp score. This is really not for general use in clinical practice, but it's mostly used in clinical trials to assess the effect of therapy on the progression of structural damage. But I do think you need to know about this measure in as much as it helps you understand the literature. And so the Sharp van der Heide scoring method, essentially each of multiple joints gets scored for erosion in the hands and the feet and in for joint space narrowing. So there's an erosion score and a joint space narrowing score, and you add that up and you get the Sharp van der Heide score for rheumatoid arthritis. Again, we're not going to spend a lot of time on that today, but I just want you to be aware of that. And these are essentially visual cues about what the different scores are. So a 0 joint space narrowing is normal joint space. A 4 would be completely, no cartilage there. And erosion scoring, again, no erosion here. And then this would be a 5. There's multiple erosions on multiple sides of the joint. You add the joint space narrowing and the erosion score together, and the range of scores goes up to 448. Again, we don't use this in our clinical practice as much as we do in our research practice. So now we're going to jump to some practice cases, and I think we've got some polling. So I'm not sure how to do this. Here we go. We got good tech support today. So so the question here is, what is your diagnosis? And you may need to move that over. Is this rheumatoid arthritis? Is this psoriatic arthritis? Is this osteoarthritis? Is it gout, or is it CPPD arthropathy? Very good. So 75% of you got it right. This is osteoarthritis, and this is osteoarthritis because of the pattern of joint involvement. This involves the PIP joints and the DIP joints, and you can see here, there's some osteophytes here, and there's sparing of the MCP joints. And here you can see involvement of the basal thumb joint. So this is pretty characteristic of osteoarthritis. Okay. We're going to go to the next slide. And again, I want you to look at this film and tell me, what is your diagnosis? Is this rheumatoid arthritis? Is this psoriatic arthritis? Is this osteoarthritis? Is this gout? Or is this CPPD arthropathy? Okay, so 80% of you said rheumatoid arthritis. Very good. So let's go over that. You've got diffuse narrowing of the MCP joints. You've got relative sparing of the DIP joints. We've got some ulnar drift at the MCP joints. And here we can see also, we didn't talk about the carpus much today, but carpal crowding. So this is rheumatoid arthritis. Very good. You guys are getting it. All right, so here's the next case. Have a look at this. Is this rheumatoid arthritis? Is this psoriatic arthritis? Is this chronic gout? Or is this erosive osteoarthritis? Okay, so we've got a bunch of answers. We got 50% of you said psoriatic arthritis, 25% of you said chronic gout, and 25% of you said erosive osteoarthritis. So I think you can narrow this down to either psoriatic disease or erosive OA. But I think this is erosive OA because of the pattern, this PIP and DIP osteophyte formation. But it's sometimes very hard to differentiate between psoriatic disease and erosive OA radiographically. But I do want to point out that there's sparing of the MCP joints, which is why this is not RA. Okay. Next one. So this patient comes to your clinic and is scheduled for left total knee arthroplasty. As you can see here, there's no cartilage. So the question for you is, which form of arthritis is most likely to have caused this patient's end-stage disease? Is it osteoarthritis or rheumatoid arthritis? All right, well, we've got a 50-50 on this one, so we've got some work to do. So in this joint, and even on the right, you can see that there's uniform joint space narrowing. And so it's most likely that this joint was damaged by an inflammatory disease. So that's more likely to be rheumatoid arthritis than osteoarthritis. Now, when you send these patients to radiology or to orthopedic surgery, they'll often read this film as osteoarthritis, and they're probably not wrong. There's osteophytes and there's end-stage disease. But what is clear from this film, because there's uniform joint space narrowing, that the process that got us here was more likely to be rheumatoid arthritis than osteoarthritis. Okay, question number 5. What is your diagnosis? Is this rheumatoid arthritis? Is this psoriatic arthritis? Is this osteoarthritis? Is this gout or CPPD arthropathy? All right, half of you got gout, which is the correct answer. And let's go through that here. So first thing, again, you're taking your systematic approach. You step back, you look at that film, and you can see lumpy, bumpy, soft tissue swelling in sort of this kind of random pattern. We've got over the ulnar styloid, there's probably a bump here over the radius, over the thumb, the second MCP, couple of PIPs. And this has become calcified. And so these are tophi, and this patient has gout. This can't really be rheumatoid arthritis. MCP joint widths are preserved, PIP joint widths are preserved. So this is gout. The other thing I will tell you that's a clue to gout, oftentimes when patients develop gouty arthritis, is the joint width is often preserved until very late. So with all this preserved joint space and this lumpy, bumpy, calcified blobs of tophi, this is gout. Okay, and this is the bonus question. This is a 45-year-old woman who's recently had a CVA, and you can see there's some neurologic impairment to that right hand. She has a history of chronic sinus disease, and she presents with hand pain. What is your diagnosis? And I want you to be looking really at this hand. Okay, is this rheumatoid arthritis? Is this osteoporosis? Is this sarcoidosis? Is it osteoarthritis? Or is this granulomatosis with polyangiitis? This is our bonus round. All right, half of you got it. Strong work. Okay, so this patient has sarcoidosis, and again, we did not go over this, so this is the bonus round. And you can see in this digit here, the bone looks very, very lacy, and that is a sarcoid bone disease. So there's periarticular osteopenia for sure. It wouldn't be osteoporosis necessarily because you can't really make a diagnosis of osteoporosis on a plain film. It's not rheumatoid arthritis, there's relative preservation of joint width, but it's this bony finding of this sort of lacy bone that makes your diagnosis of sarcoidosis. Okay, good work, everybody. So this is a really nice resource I want to point your attention to. This is a book. It was last updated about 10 years ago, but it's still an oldie but a goodie, and a really, really nice resource in looking at sort of how to systematically assess plain radiographs. So Arthritis in Black and White, great resource, and I encourage you all to get it. It's actually a very small book and it's a quick read. And it's something that I refer to all the time. So I'm going to stop there, and if there are questions, I'm happy to answer them.
All right, thank you, Dr. Jonas, for presenting some really great information for incorporating early into our practice, especially as trainees. I would certainly count reading your own radiographs as one of the fun parts of rheumatology. We have one question in the Q&A, and I think we have enough time for one or two more if anybody else wants to submit. The first question is, are osteophytes more of a characteristic feature of primary OA, or can they be seen in secondary OA as well? And I think to piggyback off of that question, are there any features that can help you distinguish between primary and secondary OA?
Yeah, good question. So we typically see osteophytes in osteoarthritis, and that can occur either in primary osteoarthritis or post-inflammatory osteoarthritis. So I don't think you can use the osteophytes necessarily at the time of end-stage disease to help you. Actually, as we sort of pointed out in that X-ray that I showed you with the end-stage knee, that patient had osteophytes, but the primary process was probably not osteoarthritis that got that person there. And you're going to use other features and perhaps even other joints to help you decide when you're seeing a radiograph whether or not that patient has primary or secondary osteoarthritis. So that's kind of a tricky business.
And I guess similar to that question, any tips or tricks for differentiating between erosive osteoarthritis and appendicular spondyloarthritis that might, for a patient with PIP swelling?
Yeah. So yeah, that's kind of, so it's really psoriatic disease and erosive OA are often the ones that we're like beating our head against the wall. Obviously, if the patient has psoriasis, that's super helpful. And you got to look. Here's my psoriasis tip. Don't forget to look in the ears, right? And all the intertriginous areas, because sometimes it'll just be there. And occasionally people are like, why are you always looking at everybody's ears? You never know what you're going to find in there. You're going to find psoriasis. You're going to find discoid lupus. You're going to find all kinds of stuff in the ears. So I always look in the ears. So even if the patient doesn't have a psoriasis history, sometimes their external auditory canals are really like yucky, so that can help you. But so you're going to use all of your clues. But if you just got the X-rays, if there is fluffy new bone formation or periostitis, that might send you more towards psoriatic disease as opposed to osteoarthritis. That's really like the only radiographic cue that you can use to differentiate those two.